When a human heart drops below 50 beats per minute, the body enters a state of severe bradycardia. The electrical impulses driving the muscle fail, placing the cardiovascular system at risk of immediate arrest. These are urgent triage thresholds. Blood potassium below 3.0 millimoles triggers an emergency. A heart QTC interval past 50 milliseconds indicates fatal arrhythmia risk. These internal failures track externally. A core temperature below 35.5 degrees and a BMI under 14 signal end-stage systemic starvation. This is the physiological reality of anorexia nervosa. The clinical presentation is a rapid, multi-system collapse that requires immediate critical care to maintain the host system. Stabilizing these urgent metrics with clinical nutrition and cardiac support addresses only the surface crisis. The central challenge is that the patient's neurological programming actively fights the life-saving physiological interventions. The brain perceives the necessary caloric and medical resources as a threat, creating a massive internal resistance to recovery. To stabilize the physiological system long-term, clinicians must reverse engineer the starvation state by targeting its neurobiological and cognitive origins. This table compares how the ICD-11 and DSM-5 categorize eating and feeding disorders. Clinicians use these classification systems to group patients based on specific, observable behaviors. Within these frameworks, anorexia nervosa is further subdivided. The manual separates the disorder by behavioral pattern, distinguishing between restricting patterns and binge-purge cycles, and classifies severity based on body weight metrics. Yet real-world patient presentations rarely stay locked in these static categories over time. As this diagram indicates, there is high probability of temporal movement. An individual can shift across the boundaries of anorexia nervosa, bulimia nervosa, and atypical eating disorders throughout their life. This diagnostic fluidity forces clinicians to look past the temporary label and isolate the shared underlying psychopathology that drives these physical states. The mechanism shared across the spectrum is a severe overvaluation of weight and shape. The patient's entire metric for self-worth is tied to a single physical parameter and their ability to control it. This manifests as a profound body image distortion. It is a specific psychiatric symptom where the internal perception of the self detaches from physical reality. The internal image no longer corresponds to the external geometry. This distortion leads to a critical lack of recognition regarding the seriousness of low body weight. It creates a lethal clinical paradox. While the medical metrics indicate a cardiovascular system nearing arrest, the patient's brain perceives the near-fatal starvation as the successful execution of its behavioral goals. The refusal to acknowledge physiological collapse is a mechanical symptom of the disease's core psychopathology. It is a failure of internal monitoring systems. If we examine the etiology flowchart, we can trace these symptoms to their biological roots, moving past socio-cultural assumptions. The disorder has a strong biological basis. Inherited genetics account for 50 to 60% of the risk factor. This genetic predisposition influences neurobiological drivers. We see specific alterations in the role of serotonin, which disrupts regulatory functions. These chemical imbalances are associated with structural and functional changes, specifically within the orbitofrontal cortex and visuospatial processing centers. These changes in the orbitofrontal cortex provide a physical basis for the persistent and recurring nature of the psychopathology. The altered neural pathways help reinforce the body image distortions we observed earlier. Because anorexia nervosa is a hardwired neurobiological condition, the host system defends its starvation state. The resulting physical collapse is the outcome of a system whose neurobiological control centers have adapted to mandate it. Treating a disease with this level of complexity requires clinicians to deploy a concurrent assessment matrix. This framework monitors the disorder through 3 active pillars. The physical pillar tracks the cardiovascular and hematological crash. Simultaneously, the psychological pillar evaluates cognitive distortion and treatment resistance, and the eating assessment pillar tracks real-time restriction and binge-purge cycles. Failing to assess all 3 pillars simultaneously creates fatal clinical blind spots, making it impossible to stabilize the patient's trajectory. Once the physical system is out of the acute danger zone and vital signs stabilize, primary therapeutic interventions are deployed. To address the neurobiological pathways, clinicians utilize evidence-based tools, including enhanced cognitive behavior therapy, cognitive analytical therapy, interpersonal therapy, and structured family therapy. These therapies are designed to systematically dismantle the overvaluation of weight and shape, allowing the brain to adopt accurate visuospatial processing over an extended period. Full recovery requires two parallel success states. Physical metrics must stabilize and return to baseline, alongside a restructuring of the patient's internal cognitive processing. True recovery from anorexia nervosa requires clinicians to simultaneously reverse acute cellular starvation while methodically dismantling the neurobiological architecture that initiated it.